So when you identify all of these risk factors and protective factors, so number one, I mean, speaking broadly, your goal should be to target these factors directly. Do what you can to bring down the risk factors.
Especially the drivers.
Especially the drivers, right? The most
Key
important ones. The ones that will most directly drive the risk of suicide. And then increase the protective factors.
Yeah.
And the protective factors are, for some individuals, when you speak to them, it may seem there are not that many, that there are not many protective factors right now.
That does
so
happen,
I think
yeah.
another word to think about, in addition to protective factors, is think about the patient's resources. And the resources could be internal, like someone with a great kind of like a degree of resilience. The life keeps pounding on them, but they kind of keep on going.
Yeah.
High intelligence, for instance, good distress tolerance skills. They could be external resources, a supportive family, the financial wherewithal to get treatment, right?
But what if there are not that many resources? We see people who don't actually have too many resources right now.
Well, I think that the good news is that there are always potential resources.
Okay.
So even if they're not existent, not present in the person's life right now,
Yeah.
that we can deploy these resources that are not existent now. But we can, that's part of our jobs, is to, whether we implement the strategies ourselves, or send them to a therapist or a social worker to, so there are plenty ways of thinking about potential resources. For instance, I mentioned about distress tolerance skills. So for a lot of patients, they may be lacking certain kind of skills, coping skills, problem-solving skills, communication skills, negotiation skills, distress tolerance skills, emotional regulation skills. But the key word there is skill. People can learn things, learn how to do things, and we can teach them. In fact, of course, when we think about dialectical behavioral therapy, one major component of that treatment is the skill groups. Right? Mindfulness skills, emotional regulation skills, interpersonal effectiveness skills. Which one did I miss? Emotional regulation, the stress tolerance skills.
Right. Great. So, let's say we assess a particular person and we looked at their past, we looked at their present, and we are trying to plan for the future, like anticipating, what things could happen in the future and what protective things can be developed in the future. So that's a great way of looking at it. Sometimes we have these people who are monitoring with suicidal ideation and we worry about them, and then the person doesn't show up for an appointment. Like, what would be your tip for that? It's anxiety provoking for the clinician. You have a person who has suicidal ideation and they didn't come today. So what would you do under such circumstances?
Right. All too often our patients miss sessions with us, and for some patients, they may be, having a milder form of generalized anxiety disorder. They miss a session. Maybe it's a business person, who's kind of stuck in Tokyo or something.
But I worry that maybe the person killed himself.
But there are some patients who we do worry about, because when they don't show up, it's just sort of like, are they in crisis? Are they moving towards going down that suicide pathway? So we have to worry. So one of the things that I teach, a practical skill, and if I can kind of say, make a statement that's more broad, the way I talk about management of suicide risk, I think about it in 3 levels. And this is just a way to organizing a very complex management plan. So level 1 is optimized as foundational psychiatric management. Number 2, as I kind of alluded to, is target the suicide-related risk factors and protective factors directly. Right. Level 3 is don't just treat the patient in the present, foresee the future, right? You have, deploy the future-focused kind of treatment.
Yeah.
But anyway, so what you asked me now leads me to talk about, just optimizing good foundational psychiatric management. By that I mean, this is what you should do for all of your patients, whether they're at suicidal risk or not. So one of the things that I have learned working with a lot of residents and doctors through my many years of doing the oral board courses, is that I think there's much too little attention paid to the beginnings of the relationship, to the beginnings of the physician-patient relationship. And I think that a lot of the headaches that we actually experience as clinicians is because we don't take the time, often because we weren't taught to establish a strong foundation. So for instance, one of the things that is not paid attention to nearly frequently enough is establishing what's called a treatment contract or treatment agreement, right? This is not the same thing as a treatment plan. It's a treatment agreement which lays out the parameters of treatment. Like, these are my fees, and this is like, if you want to cancel, you need to cancel 24 hours before, 48 hours before, otherwise I'm going to charge you. If you have me fill out forms, these are my fees. These are kind of my no-show policies. These are, in case of emergency, do this. Here's your, patient bill of rights. So those setting up, the foundation of the relationship. So in this treatment agreement, if I'm working with a patient that I'm already getting the sense that there are, a more severely ill patient at high risk of suicide, I will customize that treatment plan. So for instance, every patient, they have to give their emergency contact.
Right.
I'm going to call whoever you tell me, your mom, your dad, your spouse, whoever it is. But if someone is at high suicide risk, I might alter that and say, first of all, I want 2 emergency contacts.
Okay.
And then, because of my kind of guess or anticipation of your increased risk, I'm going to regard you not showing up to a session as a potential emergency. So if you don't show up without canceling, you just don't show up and I don't know where you are, obviously I'm going to try to reach you first, right? But what if I still don't get a response? I'm like, I don't know what's going on with this person.
Yeah.
So in that case, you're giving me permission to call your emergency contact. Just by not showing up and not being in contact.
So plan this in advance, like get this
That's
agreement.
So much of this is about planning in advance,
Yeah.
anticipating future problems and setting up the relationship and the treatment, ahead of time to try to avoid some of these, potential problems.
Terrific. Thank you, Jack. I mean, I think that it's a very nice way that you think about the suicide assessment and suicide prevention strategies as a continuum, like from the past to the present and then into the future.
Correct.
Rather than only like what is going on right now and in the next few days.
That's right. We spend too little time anticipating, what potential crises that come up. Now, we're not fortune tellers. We can't look into the future, but that doesn't mean we can't use all of this data that we have from the patient and really, at least, try to foresee the potential scenarios that can lead to future crises and to recognize what the signs of decompensation are before the patient, hits the crisis. Once there's a suicidal crisis, all bets are off. Things move so quickly. There's an increased level of unpredictability. So our goal should be, number one, of course we need to treat the patient right now in this upcoming day, week, whatever month. But we also need to anticipate the further off future, and our goal should be to help the patient avoid crises, and if we can't avoid them, to mitigate them. So, there's one thing I wanted to add is what's called a safety plan. And this is not to be confused with the no harm contract. Okay, so no harm contract is like, Raj, you're my patient. You sign here that you agree not to try to hurt yourself or kill yourself while you're in treatment with me. Okay? Those don't work.
That's worthless. Yeah.
It's worthless. And in fact, it could be counterproductive because it's just kind of, it gives people a false sense of security. That's not at all what I'm talking about. A safety plan is, so Raj, okay, so when you feel like you're in not doing well, or in your crisis, or you're really feeling kind of unsteady, like you're feeling like things may not go in the right direction, let's talk about what you can do in that time. So let me give you an example. I remember very well. I came up with a patient of mine who had, was diagnosed with borderline personality disorder. And she would, a very intelligent person, but she would often have these kind of crises she'd go into. And so then we worked out a plan. So number one, step one, like if I'm feeling bad, insecure, in crisis, whatever, bad, then number one, I will call my friend Mary. And I'd say, does Mary kind of understand about you, about your kind of like, inner thoughts and about your psychiatric, are you open with her?
Yeah.
And she said, yes. And is Mary supportive of you? Yes, she is. Awesome. That's great that you have such a good friend.
Identify a particular person.
A particular person. All right. So you're going to call Mary. Okay. We're not done. We can't just have one step. So then I would say, so what if Mary is either unavailable, right? She has her own life. Or you talk to Mary, you get off the phone, and 5 minutes later, a half hour later, you're feeling really bad. It just didn't help enough. What are you going to do? What's step two? Well, and the patient was thinking about, I'm going to call my friend Ann. Great. Now, does Ann, are you open with her? Is she a good support? Yes, she is. Okay, good. You're going to call Ann. Great. What happens if Ann's not available or it's not helpful enough? Well, I find that if I really exercise, I move, that often helps quiet my mind and I feel better, and then I can I get tired and I can go to sleep. Awesome. So what are you going to do? What do you mean exercise? Well, I'm going to go, I like taking a very brisk walk. I have a nice park by my house. Awesome. And then even before I said anything, the patient said, but as a woman, it's kind of dangerous for me to be out in this park after dark. I'm like, that's great thinking. You're thinking ahead. So you're going to go the brisk walk in the park unless it's not a good idea. So what can you do then instead?
Have a series of coping skills that they can apply.
Coping. So then she said, well, I got a treadmill in my house. I don't really like that as much as walking, but that's still good. All right. What if that doesn't help? So eventually we got to the point where she had PRN lorazepam. So if she did all those other steps, it was not enough, then she had my permission to take an extra lorazepam. And of course at the bottom of the list is whatever, call me or go to the ER or something
call
like that. Yeah, call 911.
Of course. But that's not the only thing. Often the only
That's at the
safety
bottom.
planning,
That's if all your coping strategies don't work, obviously you have to maybe you need to end up in a hospital.
Right. Terrific. Thank you so much, Jack, for talking to
Raj,
us.
thank you so much.
And all these giving us several very useful, actionable tips which we can implement in our clinical practices.
Good. Well, since you gave me this opportunity, I'm going to take this opportunity and tell you that, and your audience, that in 2017, I'm going to hold the second free suicide assessment and management course. It's completely free.
Yes.
It's April 28th, 29th, 2017 in the Chicago area, 0 cost, 2 days. I invite everyone.
April 28 and 29, 2017. Right. In Chicago.
Yes.
And where can they go to find out about this or to register for the course?
It's on my website, Master Psych, one word, Master Psych, PSYCH.com, masterpsych.com. And there's somewhere on the bottom there, or somewhere, I don't know, we're redoing it. Is going to be the suicide course. We actually have an online version now for anyone who wants to kind of start right now. And I'm going to upgrade it and have a new expanded version also in April of 2017.
And can people access this, the online training at the same website, for free? There's no cost?
There's no cost to anyone. So this is really, I feel so strongly about this, and I also feel there's a need for further training and support of in our community of psychiatrists. This is such a horribly, not only is this such a burden on our patients, but it's such a burden on us. Right. In fact, it's probably the #1 source of stress among psychiatrists, dealing with patients who are at risk of suicide. So I think this is my way of giving back to the community. There's no obligation, there's no cost. I just want to spread the word so we can kind of learn from each other and support each other. Terrific. So I appreciate this opportunity. You're giving me an opportunity to spread the word too. So thank you, Raj.
Thank you so much for doing that for our profession.
Thank you, Raj.